Hello everyone, my name is Nurein, and in this session we will cover oral mucosal infections. Infection of the oral cavity can present with different clinical features, so it's very important to take careful history, do an examination, and also identify risk factors. We have three types of oral infections, and these include fungal infections, bacterial, and viral infections, and we will focus on the first two, which are fungal infections and bacterial infections. It's very important to remember that fungal infections caused by opportunistic fungi do not cause lesions in healthy individuals. However, lesions can be seen in compromised patients. There are different types of fungal infections, and they've been classified into deep fungal infections, which we will not focus on in this session. And the other category is opportunistic fungal infections, which include Aspergillus and oral candidiasis, and we will focus mainly on oral candidiasis. Oral candidiasis is the most common form of oral fungal infection in humans, and it has a variety of clinical manifestation, making the diagnosis a bit difficult at times. It's commonly caused by Candida albicans, but it's good to remember that there are other species that could cause oral candidiasis, such as Candida glabrata, tropicalis, and cruzi. There are usually a predisposing factor to oral candidiasis, and these include extreme of age, which means elderly patients, patients with immune deficiency, such as diabetic patients, HIV patients, and patients undergoing chemotherapy, and also patients undertaking immunosuppressants, whether these are immunosuppressant medication or steroids inhalers. Also, anemic patients of any type could be predisposed to oral candidiasis. Also, suppression of the normal oral flora by taking a broad-spectrum antibiotic can lead to oral candidiasis. Patients with xerostomia, denture wearers, and high carbohydrate diet can all predispose to oral candidiasis. Epithelium with increased keratin, for instance in lichen planus, they are predisposed lesions and conditions to candidiasis, and almost any severely debilitated patients are predisposed to oral candidiasis. Oral candidiasis can be classified into acute and chronic. Acute involves pseudomembranous candidiasis, which is also known as thrush, oral thrush, and the other is erythematous candidiasis, which is also known as acute atrophic candidiasis. The chronic category involves angular cheilitis, chronic atrophic candidiasis, which is famously known as denture stomatitis, and it also include medial rhomboid glossitis, chronic hyperplastic candidiasis, and chronic mucocutaneous candidiasis. Pseudomembranous candidiasis or oral thrush is the most recognized form of candidal infection. It presents as creamy, lightly adherent plaque that can be gently striped off and easily wiped off. It's asymptomatic, however, sometimes it presents with the patient presents with discomfort on eating. Usually, the affected sites are buccal mucosa, palate, and oropharynx, and you can diagnose it clinically, or if you want to do an investigation, you can do a swab culture and you would see the Candida hyphae using gram-negative or periodic acid stryph. The treatment of oral thrush is fluconazole and itraconazole. You can also use an adjunct mouthwash, which is chlorhexidine, which is quite effective as well. The other form of acute candidiasis is erythematous candidiasis, which is due to the use of broad-spectrum antibiotic or due to the use of inhaled steroid. It can be seen in patients with HIV and patients with xerostomia. This form of candidiasis is painful and exacerbated by hot or spicy food. The mucosa appears red, shiny, and atrophic, as you can see in the picture on the right-hand side, and sometimes there would be coexisting area of thrush. Once you eliminate the cause, you treat as for oral thrush. In chronic candidiasis, we have chronic atrophic candidiasis, which is also known as denture stomatitis, and the lesion appears as redness of the palate under full or partial denture, so the patient has to be a denture wearer. It affects females more than males, and it's caused by Candida species, along with poor denture hygiene, nighttime wear of denture, or the denture could be ill-fitting denture, so the patient may be taking good care of the denture, not wearing it at night, but the denture itself is ill-fitting, so causing trauma. Also, the patient might have systemic factors such as iron deficiency or vitamin deficiency that predisposed him to denture stomatitis, or possibly that the patient is taking high amount of sugar that allows the candida to multiply as well. So how would you treat a patient with denture stomatitis? So you first have to encourage the patient to remove the denture at night, clean the denture thoroughly. If all of these are have been done, then a new denture might be required. Also, you have to ask the patient to reduce sugar intake and prescribe Mucosal gel for the patient to apply in the fitting surface of the denture before they wear it. This will help the treatment to be confined to a specific area. If you suspect systemic illness, you have to refer the patient to a GP. If there is coexisting papillary hyperplasia, of course due to the candida infection, then you might need to do a surgical removal of the hyperplasia. Also, systemic fluconazole may be used in severe cases. Another form of chronic candidiasis is angular cheilitis, which occurs at the angle of the mouth as red, cracked, macerated skin, and is caused by combined infection caused by staph, beta hemolytic streptococci, and candidal infection. Along with these bacterial and candidal organism, there might be underlying local and systemic precipitating factors such as trauma, inadequate vertical dimension, iron deficiency, and vitamin B12 deficiency. So your investigation would include full blood count to exclude hematinic deficiency, and also if the patient is a denture wearer, then you have to exclude local factors. Then you would treat the lesion using Mucosal gel, which is usually Mucosal cream, which is usually very effective. We also have medial rhomboid glossitis, which is another form of chronic atrophic candidiasis. It appears as well-demarcated erythematous zone on the dorsum of the tongue. It could also appear on the palate, and when these two lesions appear at the same time, it's called kissing lesion. It's seen in patients using inhaled steroids and smokers. You would do full blood count to exclude hematinic deficiency, and you would treat if the lesion is symptomatic and causing discomfort. However, otherwise, the appearance would not be changed. Chronic hyperplastic candidiasis is commonly seen in middle-aged men who are heavy smokers. It's typically seen as white patches on the oral commissural buccal mucosa bilaterally or in the dorsum of the tongue. This lesion is considered a pre-malignant lesion, so therefore you have to follow up the patient regularly. You would take biopsy to confirm the diagnosis, and in the biopsy you will see candidal hyphae in the superficial layer of the epithelium. Your management would be to eradicate fungal infection and correct any hematinic deficiency and smoking habit as well. Your treatment would be systemic antifungals such as fluconazole and itraconazole. The second section of this session would be on bacterial infections, and these could be systemic infections such as scarlet fever, granulomatous such as syphilis and TB, leprosy and actinomycosis, sexually transmitted disease such as syphilis and gonorrhea, and there are other bacterial infections as well that are not classified, such as necrotizing ulcerative gingivitis, noma, and osteomyelitis. Scarlet fever is systemic infection caused by group A and beta hemolytic streptococci. It commonly affects children of 3 to 12 years of age. The symptoms include sore throat, general malaise, fever, and characteristic red rash. When you look at the signs clinically, you would see enanthem and exanthem. Enanthem means rash on mucous membrane, and exanthem means rash on the skin with fever. Oral manifestation include reddened oral mucosa and white coating on the dorsal surface of the tongue, which is called white strawberry tongue. Later, this white coating is shed and the dorsum becomes smooth and red with enlarged fungiform papillae, and then it's called raspberry tongue. So your diagnosis would be based on clinical feature, or if you want, you can take a swab from the throat. Your treatment would be based on penicillin or amoxicillin, and if the patient is allergic to these, then you can give the patient azithromycin or clindamycin. TB is a chronic infectious disease caused by Mycobacterium tuberculosis, and there are 3 different types of TB infection. There are primary, secondary, and miliary TB. The primary TB occurs in unexposed people, and it's the result of direct person-to-person spread through airborne droplets. The secondary is the reactivation of the primary, so the patient has been previously exposed to the disease or the bacteria. This reactivation is typically associated with compromised host defense. So if the patient is not immunologically able to defend the system, the body system, then the patient will have secondary TB. Miliary TB is diffuse dissemination through the vascular system of the foci of infection. So the spread of infection is called miliary TB. Oral lesions that are seen in patients with TB are uncommon but can be seen. The most common presentation is chronic ulceration or swellings, as you can see in the pictures on the right hand side. There are less frequent features, and these are non-healing extraction socket and also area of mucosal granularity. You can confirm your diagnosis by tuberculin skin test or Mantoux test. You can also culture the infected sputum using Ziehl-Neelsen stain or acid-fast stain. Syphilis is a worldwide chronic infection produced by Treponema pallidum. The primary mode of transmission is sexual contact or from mother to fetus, and that one is called congenital syphilis. For the one that is transmitted through sexual contact, there are 3 forms or 3 stages of the disease. They are primary syphilis, secondary, and tertiary syphilis. And remember that the first 2 stages are highly infectious. Primary syphilis is characterized by chancre, which is a firm, painless, ulcerated nodule that appears 3 to 90 days after initial exposure. The common site for chancre is genital area, but can also be seen in oral mucosa. 40% of chancre can be seen in the oral mucosa. The lesion heals within 3 to 8 weeks. Chancre is mostly seen on the lip, buccal mucosa, tongue, palate, gingiva, and tonsils. The lower lip is commonly affected in males, whereas the lower lip is affected in females. Secondary syphilis is discovered usually 4 to 10 weeks after initial infection, and patients usually complain of painless lymphadenopathy, sore throat, malaise, and headache. So the signs include diffuse painless maculopapular rash in the skin and also can be seen in the oral cavity. Spontaneous resolution usually occur within 3 to 12 weeks. However, relapse may occur during the next year. Other lesions that can be seen in secondary syphilis are snail track ulcer and condylomata lata. Tertiary syphilis, on the other hand, develops only in 30% of affected individuals after a period of latency. And the period of latency could be years, 10 years, 20 years. And this stage includes the most serious of all complications. Why? Because it affects the vascular system, the central nervous system, the eye, the skin, and internal organs with a scattered foci granulomatous inflammation known as gamma. Gamma is a necrotic granulomatous lesion that usually affects the palate or tongue, which enlarges and ulcerates and may lead to perforation of the palate. Congenital syphilis, on the other hand, presents with a triad called Hutchinson triad, in which you would see Hutchinson teeth, ocular interstitial keratitis, and eighth nerve deafness. Penicillin is the treatment of syphilis. It's just as simple as that. For primary and secondary and latent, you would give the patient penicillin G, and for late and tertiary syphilis, you will give the patient IM penicillin for 3 weeks. And if the patient has penicillin allergy, then you would give doxycycline.